Consider the pinnacle of engineering for a moment.
Okay.
If you were to look at the human body, purely as a collection of mechanical and electrical systems.
Right, just the raw plumbing and wiring.
Exactly. Your immediate instinct is probably to crown the brain, or maybe the four-chambered muscular pump of the heart as the absolute marvels of evolution.
Which is fair. I mean, they are impressive.
They are. But I want you to visualize something significantly more delicate today. Picture the most high-maintenance, metabolically ravenous, absolutely unforgiving luxury sports car engine ever conceived.
Oh, I like where this is going.
We're talking about an engine tuned to such extreme, ridiculous parameters, so hypersensitive to its microvascular fuel lines that a momentary microscopic fluctuation in perfusion pressure could trigger a catastrophic, irreversible misfire in its neural circuitry.
Yeah, because it is a tissue that demands absolute, flawless hemodynamic perfection at every single millisecond of its existence. Or it simply initiates apoptosis and dies.
Right. And that biological engine is the human retina. Welcome, everyone, to Off the Record.
Glad to be here.
I am thrilled you are joining us today for an analysis that will, frankly, fundamentally alter how you view the interconnectedness of your own systemic physiology.
It really will. Because the central thesis we are exploring in this deep dive is this: when we look into the back of the eye, we aren't just looking at an isolated optical sensor.
No, not at all.
We are looking directly through a beautifully clear, illuminated window at the real-time systemic health of the entire cardiovascular network, the cerebral architecture, and the renal system.
It's just wild to think about.
It is. It is the only place in the human body where we can directly, non-invasively visualize the microcirculation. If the plumbing in the retina is under siege, you can guarantee the exact same microscopic destruction is happening in the nephrons of your kidneys and the white matter tracts of your brain.
It's all connected. But before we get into the heavy pathophysiological machinery, we really must acknowledge the machinery of this show.
Well, we definitely do.
Our director, Ryan Thomas, has engineered an environment today that is frankly intimidating. We are sitting in front of a sprawling, decadent charcuterie board. I'm looking at imported cured meats with molecularly perfect fat distribution, aged cheeses paired with a massive, incredibly rich cut of prime rib.
And critically, to accompany this massive influx of lipids and proteins, Ryan has curated our drink pairing, which I have some thoughts on.
It's aggressive.
It is an aggressively large, deeply intimidating flight of high-proof, incredibly rare, unfiltered bourbons. Some of these are hovering around 130 proof. I mean, I can literally see the volatile organic compounds evaporating off the meniscus in the glass right now.
It is a very serious pour. But the laws of Off the Record dictate that we partake. So cheers to you and cheers to Ryan in the booth.
Cheers.
Okay, wow. That is a massive hit of ethanol.
Yeah.
The heat profile on that is immediate.
It's incredibly intense, a huge wave of tannins and char. My oral mucosa is already mounting an inflammatory response.
It burns, but, it's complex. Let's channel that intensity back to that luxury engine, the retina. Because to understand the pathology we are dissecting today, you must first understand the baseline hemodynamics.
Right, the normal state of affairs.
Exactly. The retina is this incredibly dense, multi-layered sheet of neural tissue taking photons and transducing them into electrical action potentials. The oxygen extraction ratio is just off the charts.
It's so hungry.
To fuel this, it utilizes a dual supply system. The inner layers are fed by the central retinal artery, and the outer layers, the photoreceptors, are nourished by the choroidal circulation via the posterior ciliary arteries.
And those posterior ciliary arteries are fascinating because they are true end arteries.
Which means
there is no collateral circulation. If one goes down, the tissue it supplies is entirely out of luck. But what makes this vascular network so miraculous is its intrinsic autoregulatory capacity.
Right.
The retinal vessels operate entirely independently of autonomic sympathetic innervation. They rely on the myogenic response, the Baylis effect, and local metabolic feedback.
So when your systemic blood pressure spikes, because, say, you sprint up a flight of stairs, the smooth muscle cells and the walls of those tiny retinal arterioles literally sense the stretch.
They physically feel it.
Yeah. Those stretch-activated calcium channels pop open, calcium floods into the intracellular space, binds to calmodulin, and activates myosin light chain kinase. The vessel wall forcefully constricts, clamping down to prevent that massive wave of hydrostatic pressure from obliterating the delicate capillary beds downstream.
It's an elegant survival mechanism. The arterials act as microscopic shock absorbers, perfectly calibrating the downstream pressure. But, well, this brings us to the core pathology we are examining today in this deep dive.
Hypertensive retinopathy.
Exactly. The progressive microvascular destruction that occurs when those autoregulatory shock absorbers are subjected to a relentless, unyielding, chronic state of systemic hypertension. They are essentially crushed under the weight of an endless siege.
And the etiology driving that siege is critical. Essential hypertension accounts for the vast majority of cases. That slow, insidious, polygenic accumulation of endothelial dysfunction, elevated peripheral resistance, and environmental factors.
Everyday stuff.
But the source material dives into secondary hypertension,
Yeah.
and the biochemical cascades here are staggering.
Oh, the secondary causes are these cinematic villains of endocrinology. Take a pheochromocytoma, for instance.
Just the pathophysiology of a pheochromocytoma is terrifying.
It really is.
You have a chromaffin cell tumor, usually in the adrenal medulla, that entirely bypasses normal sympathetic feedback loops. It acts as an autonomous factory, relentlessly converting tyrosine to dopa, then dopamine, and finally just dumping massive unregulated boluses of norepinephrine and epinephrine directly into the systemic circulation.
Your alpha-1 adrenergic receptors are absolutely saturated. The phospholipase C pathway goes into overdrive, generating IP3, flooding the vascular smooth muscle with calcium. You get this extreme, systemic, rigid vasoconstriction. Your blood pressure skyrockets to, 250 over 140, and the delicate retinal vessels are suddenly facing a hydrostatic tsunami.
And Cushing syndrome does something similar, but through a completely different mechanism.
Right, cortisol.
Exactly. The excess cortisol heavily upregulates those exact same alpha-1 receptors, making the vasculature hyper-responsive to ambient catecholamines. Add in hyperaldosteronism, where the adrenal cortex overproduces aldosterone, aggressively forcing the renal distal tubules to retain sodium and water.
Massively expanding the plasma volume.
Yeah, so you're increasing both the fluid volume and the resistance of the pipes simultaneously.
Then you throw the compounding metabolic risk factors on top of it, like diabetes mellitus, you have chronic hyperglycemia driving the formation of advanced glycation end products, or AGEs.
Nasty little molecules.
They really are. These rogue molecules literally cross-link with the collagen in the vascular basement membranes, thickening them and destroying their structural integrity. When a diabetic patient also has hypertension, the synergistic destruction of the microvasculature is devastating.
And don't forget tobacco smoke.
No, right.
The sheer volume of reactive oxygen species inhaled during smoking rapidly depletes endogenous nitric oxide. The endothelial cells lose their primary vasodilatory molecule. You are essentially stripping away the vessel's ability to relax, leaving it in a constant state of rigid spasm. Plus, age.
Yeah, time gets us all.
The natural degradation of elastin and the deposition of stiff collagen fibers over decades.
The inevitable march toward vascular rigidity.
Reading the biochemical breakdown of elastin degradation earlier today really put me in a profound state of melancholy.
Did it really?
It did. Let's take another pull of this 130-proof monster.
We're going back in, all right? Bottoms up.
It's just the concept of losing arterial compliance. You cross a certain threshold in your life, and you realize you aren't a network of highly adaptive rubbery vessels anymore.
You're feeling your mortality.
I am. The autoregulatory reserve of my youth is it's gone. I sit at my desk with poor posture, and my sheer lack of vascular elasticity means my knee aches for 3 days. My large arteries are stiffening. I'm just sitting here, a collection of rigid, calcified pipes, forcing my struggling myocardium to pump this incredibly heavy tannic bourbon through a hostile vascular environment.
God, this bourbon is actively hostile.
It really is.
It's so hot on the palate. I really don't understand why Ryan Thomas insists on utilizing these barrel-proof biological weapons against us. It's like he specifically desires the destruction of our endothelial linings.
He's a menace.
He sits back there, safe behind the acoustic glass of the booth, feeding us firewater and massive quantities of animal fat, just studying our hemodynamic collapse.
Your face is already experiencing profound vasodilation, by the way.
I know. I can feel it. My capillaries are engorged. The ethanol is actively inhibiting my antidiuretic hormone and flushing my system. But, looking at him back there.
Look at who? Ryan?
Yeah. He does have really beautifully structured eyes, though.
Wait, what are you talking about?
I'm just looking at the biomechanics of his face. If we're establishing that the eye is a clear window into systemic health, Ryan's ocular windows are deeply structurally magnificent.
Okay.
I actively hate him for pouring this fiery poison, but his posterior ciliary arteries must be absolutely pristine.
Mhm.
Just flawless, unobstructed flow.
Okay. We are diverging. Let's redirect our focus back to the clinical text.
Right. Back to the literature.
We need to dissect how this damage actually manifests at the tissue level, because the pathophysiology of hypertensive retinopathy unfolds in a highly specific chronological cascade. Let's analyze the initial defense mechanism, the vasoconstrictive phase.
So when that systemic pressure wave initially hits the central retinal artery, the arterioles initiate an extreme myogenic spasm. This isn't subtle. On a fundoscopic exam, you will see generalized, diffuse narrowing of the blood column and often focal arteriolar spasm, where specific segments just cinch down completely. The vessel is desperately trying to increase resistance to drop the downstream pressure, protecting the capillary beds.
But biological systems cannot maintain a state of maximum emergency contraction indefinitely. The smooth muscle cells require massive amounts of ATP to keep those actin and myosin filaments locked. If the systemic hypertension is chronic, this persistent vasospasm induces profound hypoxia in the vessel wall itself.
It starves itself.
Exactly. The endothelial cells become deeply dysfunctional. They stop producing nitric oxide and start upregulating inflammatory cytokines.
Which seamlessly transitions the pathology into the sclerotic phase.
Phase 2.
Yep. The body recognizes that this high-pressure state is the new baseline, so it attempts to remodel the pipes to withstand the sheer mechanical stress. You get dramatic structural alterations. That delicate inner lining undergoes extreme thickening. The media experiences smooth muscle cell hyperplasia, where the cells physically multiply, followed by hypertrophy, where they swell in size.
And the most visually striking pathological change is hyaline degeneration.
Oh, yeah.
The endothelial barrier breaks down just enough that plasma proteins leak into the vessel wall, becoming trapped in the extracellular matrix. It turns the vessel wall into this stiff, opaque, glassy, fibrotic tube. The optics of the vessel completely change.
The clinical signs of this are fascinating. When an ophthalmologist looks at a healthy retinal arteriole, it's mostly transparent. What you are actually seeing is the red column of erythrocytes flowing inside, with a tiny, crisp reflection of the ophthalmoscope's light bouncing off the convex surface of the blood column. It's called the light reflex.
But as that vessel wall undergoes intimal thickening and hyaline degeneration, the wall itself becomes optically dense and opaque. It widens that light reflex. The red color of the blood column becomes obscured by the thickened fibrotic wall, giving the vessel a distinct, burnished, yellowish-orange metallic glare.
The classic copper wiring sign.
Right, copper wiring.
And if the hypertension remains uncontrolled, the sclerosis progresses until the lumen, the actual internal diameter of the pipe, is almost entirely obliterated. No blood is visible at all. The entire vessel just heavily reflects the light as a solid, brilliant white line. That is silver wiring.
The vessel is functionally dead,
Just a rigid fibrotic cord.
which sets up the physical mechanics for one of the most famous diagnostic markers in ophthalmology, arteriovenous nicking, or AV nicking.
The anatomy here is the entire reason this happens. In the retinal nerve fiber layer, the arterioles and venules frequently cross paths. And at these specific crossing points, they don't just lay on top of each other, they actually share a common adventitial sheath.
They were bound together tightly in the same fibrous connective tissue wrapping.
So, under normal physiological conditions, they coexist peacefully within that shared sheath. But when that arteriole undergoes massive sclerotic remodeling, when it turns from a soft, flexible tube into a rigid, hypertrophic, high-pressure silver wire, it physically expands outward.
Because it's trapped in that shared adventitial sheath,
Yeah.
it has nowhere to expand except directly down into the soft, low-pressure venule underneath it.
It literally crushes the vein. The rigid arterial wall encroaches on the venous lumen, significantly altering the transmural pressure. It creates a physical bottleneck.
It's the exact fluid dynamic equivalent of having a soft, flexible garden hose running across your driveway, and suddenly a massive, heavy, rigid steel pipe is dropped directly across it.
That's a great analogy.
The steel pipe restricts the diameter of the hose. Upstream from the crush point, the water, or in this case the venous blood, backs up. You get turbulent flow, venous engorgement, and intense stasis.
And that venous stasis vastly increases the hydrostatic pressure inside the capillary beds, which is the exact thing the arterioles were initially spasming to prevent. It's a vicious, self-defeating biomechanical loop.
Oh, God. Ryan just hit the red prompt light.
Are you serious? We are literally in the middle of explaining transmural pressure gradients.
The rules of the studio are non-negotiable. When Ryan flashes the red light, we are contractually obligated to execute the vocal warm-up to prove our articulation hasn't degraded from the bourbon.
Fine.
Okay. Deep breath. Sync up with me. 3, 2, 1.
Liam Neeson's niece, Lisa Neeson, recently leased a really nice Nissan.
Liam Neeson's niece, Lisa Neeson, recently leased a really nice Nissan.
Oh my God, leased a really nice Nissan.
A really nice Nissan. Why is the phonetic transition from leased to really so incredibly difficult for my tongue right now? Lisa Neeson.
It's the alveolar taps. The least are really nice, just liquefies in my mouth, especially with the tannins and this bourbon coating my hard palate.
Hey, listen to me. While we are derailing deep pathophysiological analysis to perform phonetic gymnastics for Ryan Thomas, you need to do something for us. You, the listener, go to your browser, go to our YouTube channel right now, HamOTR.
Yes. HamOTR, type it in.
It is the official, canonical visual archive for Off the Record. I am imploring you, with every ounce of sincerity in my cardiovascular system, please just click the button, like, and subscribe.
We desperately need the algorithm validation. Like and subscribe to HamOTR. Ryan explicitly threatened that if our engagement metrics don't hit the target, he's going to replace these incredibly complex, high-proof bourbons with bottom-shelf, well, tequila. I cannot process complex pathophysiology on well tequila. We are esteemed professionals. Please subscribe.
Okay, let's recalibrate. My heart rate is distinctly elevated.
Same.
Let's take another sip of the high-proof firewater and pull ourselves back into the literature. We were establishing the physical bottleneck of the crushed garden hose.
Yes, the AV nicking. The upstream venous engorgement. Because when that hydrostatic pressure builds up behind the crush point, the capillary beds are pushed beyond their structural limits, which plunges us into the exudative phase.
Right.
My blood-brain barrier is currently negotiating a rapid surrender to this ethanol, but in the retina, the blood-retinal barrier literally tears apart.
The zonula occludens, the tight junctions binding the endothelial cells together, fail catastrophically under the mechanical stress and the inflammatory cytokines. The structural integrity is gone. The Starling forces shift entirely in favor of massive fluid extravasation. And the clinical manifestations are brutal. First, you get retinal hemorrhages. The vessels physically rupture.
And the shape of the hemorrhage tells you exactly what anatomical layer of the retina is bleeding. If the capillary bursts in the superficial nerve fiber layer, the blood tracks along the horizontal axons, creating a classic flame-shaped hemorrhage.
Yeah.
If it bursts deeper in the internuclear or outer plexiform layers where the cells are packed vertically, it looks like a concentrated red dot blot hemorrhage.
Alongside the blood, you have lipid exudates. As the serum leaks out of the broken vessels, macrophages rush in to phagocytize the escaped lipoproteins. These engorged, lipid-laden macrophages cluster together, forming these hard, waxy, yellow deposits.
They look so strange on imaging.
They really do. In the macula, they often arrange themselves in a distinct macular star pattern because of the radial orientation of the retinal nerve fibers.
And then we reach the ischemic consequences, the cotton wool spots.
I have to be completely honest with you right now.
Uh-oh, what?
When I was reviewing the histologic breakdown of this phase earlier today, the terminology it genuinely broke my heart.
Broke your heart. We are talking about necrotic tissue.
I know, but just listen to the phrase, cotton wool spots. It sounds so incredibly soft. It sounds so delicate and lovely.
It's pathology, man.
But it evokes images of a quiet, warm baby's nursery or a peaceful craft store. Little fluffy, benign clouds of cotton wool just resting gently on the surface of the retina. It sounds like comfort.
It is the literal microscopic opposite of comfort.
Exactly. That is why it is so profoundly sad. It is a devastating, cruel trick of medical nomenclature. Because when you actually look at the cellular reality, a cotton wool spot represents a localized, acute nerve fiber layer infarction.
Driven by the complete occlusion of a terminal precapillary arterial.
It is a microscopic stroke in the eye. The blood supply is severed, the oxygen tension plummets to zero, and the axoplasmic transport inside those neurons violently halts. The mitochondria, desperate for ATP, just swell up and die.
Yeah, they do.
You are looking at a microscopic graveyard of suffocated nerve fibers. That specific little patch of miraculous neural tissue, whose only job in the universe was to carry light to the brain, just starves to death in the dark. And it leaves behind this pale, fluffy-looking scar of cellular debris that we cynically call a cotton wool spot. It's a tragedy. All those little mitochondria just trying to power the action potentials and the systemic pressure just eradicated them.
You are becoming intensely emotionally invested in the fate of these subcellular organelles.
They didn't ask for the systemic hypertension. They were just doing their jobs.
Okay, you need to hydrate.
Right.
Or just drink more of the 130 proof because the pathology is about to accelerate into a total systemic meltdown. Phase 4, malignant hypertension.
Oh, God.
This is where the compensatory mechanisms don't just fail, they undergo complete catastrophic disintegration, fibrinoid necrosis of the arterioles, the walls literally turn to mush.
Malignant. The terminology is terrifyingly accurate.
It is an absolute hypertensive emergency. The autoregulatory curve is shattered. Massive, unmitigated systemic hydrostatic pressure violently slams directly into the delicate vascular beds of the eye and the brain simultaneously. And the hallmark sign is papilledema, optic disc edema.
The optic nerve head, the main data cable connecting the globe of the eye to the visual cortex, becomes massively swollen, choked by the intracranial pressure and the local ischemic breakdown. The margins of the disc blur, the cup is obliterated.
Just a total disaster area.
You get severe choroidopathy, where the vascular bed under the retina is destroyed, leading to Elschnig spots. The retinal pigment epithelium fails, and fluid physically peels the retina off the back of the eye, a serous retinal detachment.
It makes me incredibly physiologically angry on behalf of the retinal tissue. The retina spent years trying to regulate, trying to clamp down, trying to hold the line against this relentless pressure, and the systemic environment just overwhelms it. When autoregulation fails at this level, the entire vascular network just becomes an absolute fuck.
An absolute fuck.
Yeah.
This is the only clinically appropriate term for it.
It truly is. It is a complete unmitigated fuck. The tight junctions are shredded, the axoplasm is stagnant, the photoreceptors are detaching. Papilledema is a massive red flag for severe end organ ischemia. As you see a choked optic disc from hypertension, the literature is extremely clear. It carries a staggering mortality rate if not immediately managed. The brain is quite literally swelling inside the skull alongside it.
It's the visual manifestation of a hypertensive crisis.
But you know what hasn't succumbed to fibrinoid necrosis? Your intimal thickening.
I would.
I'm just observing you across the console right now. The deep, profound empathy you were just displaying while mourning those little hypoxic mitochondria, it was incredibly endearing. I bet the smooth muscle hyperplasia in your media is just phenomenally robust.
Wait, really?
Like, I genuinely believe you possess incredibly thick, structurally dominant vascular walls.
You realize that makes absolutely zero anatomical sense as a compliment, correct? Intimal thickening and medial hyperplasia are severe pathological signs of arteriosclerotic disease. You're complimenting my morbid cardiovascular decline.
I am speaking metaphorically. I am attempting to articulate that you have a very solid, commanding, highly vascularized presence. Your hemodynamics feel very firm to me right now.
Are you attempting to flirt with me by utilizing the pathophysiology of chronic hypertensive vascular remodeling?
I am absolutely utilizing it. Is it generating a response in your sympathetic nervous system?
It is generating profound cognitive confusion, but I am bizarrely not opposed to it. Let's stabilize our blood sugar. I need a piece of this prime rib. Oh, man. The lipid profile on this is absurd. The fat is literally melting at room temperature.
It is spectacular. Ryan, I know I called you a sadistic architect of our demise, but this protein is flawless.
Okay, let's push into the clinical symptoms, because this is the terrifying reality for you, the listener. The insidious nature of this disease is that it is fundamentally silent for years.
So silent.
You could possess profound copper wiring, severe AV nicking, and microaneurysms actively forming right this second as you listen to this deep dive, and your central nervous system would register absolutely nothing.
You feel completely fine. Your visual acuity is 20/20. You are just walking through your day, blissfully unaware that a microscopic garden hose is being brutally crushed in the back of your skull.
But when the disease progresses to the point of compromising the macula or the optic nerve, the symptoms manifest abruptly. The literature details the presentation, blurred vision, a generalized drop in visual acuity. Scotomas dense, absolute blind spots in your visual field caused by those localized nerve fiber infarctions. Severe headaches secondary to the skyrocketing intracranial pressure.
Diplopia, double vision. Because the ischemia isn't just affecting the retina, it can infarct the vasa nervorum, the tiny blood vessels supplying the cranial nerves. You knock out the abducens nerve, cranial nerve 6, and suddenly your lateral rectus muscle is paralyzed. Your eyes can't track together. And my absolute favorite diagnostic phrase, transient visual obscuration.
It sounds like a melancholic weather forecast. We're expecting some heavy cloud cover and transient visual obscurations rolling in from the Pacific.
Right. But the physiological reality is terrifying. It means your vision just briefly, abruptly grays out or goes entirely pitch black for a few seconds, typically when you stand up or change posture. The swollen optic nerve physically pinches off its own already compromised blood supply, causing a momentary total cessation of action potentials to the brain.
To systematically categorize this destruction, the medical community utilizes a highly specific grading rubric, the Keith-Wagner-Barker classification system. Say that 3 times fast with 130 proof bourbon in your system.
I absolutely cannot execute that phonetic sequence right now. My motor cortex is rejecting the request,
Yeah.
but I can break down the criteria. Grade first is the earliest clinically visible sign, mild generalized arterial or narrowing, just the initial sustained myogenic squeeze.
Grade 2 implies a more severe chronic state. The narrowing is pronounced and you begin to see the mechanical crush injuries, the AV nicking.
And then grade third is when the structural integrity of the vessels. Wait, what the hell was I just saying?
Grade 3, we're analyzing grade 3 of the Keith-Wagner-Barker scale.
Right, grade third. Thank you. My working memory just dropped the packet. Grade third is the exudative phase. The blood-retinal barrier fails, hemorrhages, the tragically sad little cotton wool spots, the lipid exudates.
And grade 4 is the ultimate escalation, the presence of all grade 3 signs, plus the defining feature, papilledema, the swollen optic disc, which historically, before the advent of modern antihypertensive pharmacology, correlated with a massively accelerated trajectory toward cardiovascular mortality.
You know, I was just thinking about something.
Thinking about what?
The optic nerve, the structure of it. It connects the globe of the eye directly into the cranial vault, to the brain.
Yes, that is its primary anatomical function.
No, but pause and deeply, profoundly consider the embryology of that.
I am considering it.
The eye is physically connected to the brain. It is not just a high-tech peripheral camera floating autonomously in your orbital socket, beaming signals via Bluetooth. There is a massive myelinated cable, the optic nerve. It projects directly from the back of the eye straight through the optic canal right into the central nervous system.
That is correct.
That is staggering. During embryogenesis, the optic vesicles literally evaginate. They push outward from the diencephalon. The retina is not a separate organ. It is central nervous system tissue. It is brain tissue.
Oh my God, you're entirely right.
Right.
The retina has glial cells. It has astrocytes. We are literally staring at a piece of the human brain.
We are. When an ophthalmologist uses a slit lamp to look at the retina, they are performing a direct, non-invasive, perfectly illuminated, real-time brain biopsy. Why is this not discussed with a sense of immense philosophical awe?
I don't know. It feels like an incredibly guarded secret. We just conceptually uncovered this. If the tissue of the eye is embryologically derived from the diencephalon, then the blood vessels supplying that tissue are fundamentally cerebral blood vessels.
Yes, that is exactly the point. The vascular architecture is identical. The mind-body dualism is an absolute myth. It's all just one beautifully complex, interconnected, squishy hydrostatic machine.
This is a monumental revelation. We need to document this synthesis. Ryan, are you archiving this audio? Of course you are. This is off the record. This is the caliber of profound, paradigm-shifting insight our listeners subscribe for. The eye is the brain.
I need a massive influx of ethanol to process the magnitude of this reality.
I'm with you. Let's pour the third glass. The incredibly dark, viscous liquid from the asymmetrical bottle.
Pour it up.
Oh, wow. That is aggressive. That tastes like an extinguished campfire wrapped inside an antique leather shoe, soaked in vanilla, but in a deeply sophisticated way.
The flavor profile is assaulting my tongue. Let's transition to the diagnostic methodology. Diagnosis and the differential.
Right. The diagnostic protocol. We must maintain our scientific rigor. Let me reset my posture. The diagnostic algorithm requires a comprehensive synthesis of both ophthalmic evaluation and systemic cardiovascular assessment. We initiate with a rigorous patient history. Clinicians must evaluate the chronicity of the hypertension, the adherence to pharmacological regimens, which, let's be honest, is universally abysmal, and the comorbid presence of diabetes or renal pathology.
Your attempt at an authoritative baritone is incredibly amusing to me right now, given your blood alcohol content.
I am a conduit of peer-reviewed data. We are detailing the physical examination. Highly accurate sphygmomanometry is paramount. Severely elevated systemic pressure readings are highly indicative of an impending hypertensive crisis.
Okay, Dr. Broadcaster. The absolute cornerstone of the diagnosis is fundoscopy, direct or indirect ophthalmoscopy, projecting a beam of light through a condensing lens to actively visualize the arteriolar narrowing, the AV nicking, and the flame hemorrhages in real time.
And you absolutely must administer mydriatic drops to dilate the pupils.
Yeah.
A comprehensive dilated fundus examination. You cannot assess the peripheral retina through a constricted pupil.
Then you elevate to high-resolution imaging modalities. Fundus photography to objectively document the vascular architecture, and OCT, optical coherence tomography.
OCT is technological sorcery. It utilizes low-coherence interferometry, bouncing near infrared light waves off the retinal layers to construct micrometer resolution, cross-sectional images of the tissue. It is wildly precise. It can quantify the exact thickness of the macula, identify the precise volume of subretinal fluid and intraretinal cystic spaces caused by the failing blood-retinal barrier.
And fluorescein angiography. This is the gold standard for visualizing vascular dynamics. You inject sodium fluorescein dye directly into a peripheral vein, usually in the antecubital fossa, and then you fire a rapid sequence of photographs using a specialized blue excitation filter as the dye transits through the retinal circulation.
Yeah.
The arm-to-retina transit time is critical. As the dye hits the eye, the entire vascular tree intensely hyperfluoresces.
It creates these hauntingly beautiful glowing maps of the vasculature. But critically, it reveals the pathology you can't see with a normal lens. It highlights capillary non-perfusion, vast, dark areas of the retina where the capillaries have simply died and no dye enters at all, and it brilliantly illuminates the microaneurysms and the exact points of vascular leakage where the dye actively plumes out into the surrounding tissue.
It's stunning, but it also necessitates a rigorous differential diagnosis.
Right.
Because when you visualize a battered exudative retina, hypertensive retinopathy is not the only culprit. You must clinically distinguish it from parallel pathologies.
Like what?
Diabetic retinopathy, which often presents concurrently.
Hmm.
Central or branch retinal vein occlusions, where a thrombus physically blocks the outflow. Pepidema, secondary to benign intracranial hypertension or a space-occupying lesion like a meningioma, physically pushing the cerebrospinal fluid pressure up. And wait, radiation retinopathy.
Yeah. Radiation damage to the vascular endothelium.
Radiation retinopathy it sounds apocalyptic, like you stare directly into the core of a functioning nuclear reactor. Are there ambient microwaves in this studio, Ryan? Are you actively subjecting us to ionizing radiation?
Hey, calm down. Take a breath. It's almost exclusively a delayed complication of external beam radiation therapy or brachytherapy for head and neck malignancies. The ionizing radiation causes double-strand DNA breaks in the endothelial cells, leading to a slow, progressive apoptosis months or even years after the exposure. Ryan is not radiating us. He's merely inducing acute ethanol toxicity.
Oh, right. Okay, the prefix radiation just triggered a profound sympathetic panic response. What else is on the differential list?
Autoimmune vasculitis, systemic lupus erythematosus, polyarteritis nodosa, conditions where circulating immune complexes deposit in the vessel walls and activate the complement cascade, triggering massive localized inflammation. Which, you know what? I deeply resent Ryan Thomas for this.
You resent him. Why?
Because he utilizes his directorial power to force us to intensely study horrifying immune system malfunctions like autoimmune vasculitis, while simultaneously feeding us 130 proof neurotoxins. Do you comprehend how psychologically depressing that is? Your own adaptive immune system, the very mechanism designed to protect you, just spontaneously decides to mount a lethal attack on your own endothelial cells. It's the ultimate biological betrayal. Why are we required to internalize this darkness?
Because it is our mandate. We are the educational vanguard.
I don't want to be the vanguard right now. I want to abdicate my responsibilities. I want to I want to breach the acoustic door to the control booth and kiss him.
You want to forcefully kiss Ryan, the tyrannical director you just claimed you deeply resented for poisoning our livers and forcing us to confront the reality of systemic lupus?
It is an incredibly layered, highly complex emotional dynamic. He is a sadistic taskmaster, but he procures objectively flawless charcuterie. And, as I previously stated, his ocular structure is genetically superior. I am experiencing fiercely contradictory, intensely overwhelming emotions toward the booth right now.
Okay, we need to artificially induce some structure here. Let's ground ourselves. We are moving to the final clinical block. Treatment, prognosis, and prevention. We are heavily slurring, our higher executive functions are fading, but we are going to drive this complex pharmacological data into the listener's brain.
Treatment protocols. This is the absolute crux of the source material.
Mm.
Systemic treatment. The literature is unequivocal. Aggressively controlling the systemic blood pressure is the only definitive intervention. You can laser the retina all you want, but if the central aortic pressure remains at 220, you are just aggressively bailing water out of a submarine with a totally shattered hull.
Right. The therapeutic targets are preventing further microvascular remodeling, reducing the hydrostatic pressure, driving the macular edema, salvaging visual acuity, and most critically, mitigating the imminent risk of a catastrophic cerebrovascular accident. Because, as we established in our moment of profound brilliance, if the vessels are failing in the eye, the identical vessels are failing in the brain.
So we deploy the heavy systemic antihypertensives. The text details the pharmacological arsenal: ACE inhibitors, lisinopril, and olaparib. These molecules are incredible. They directly block the angiotensin-converting enzyme in the pulmonary capillaries, halting the conversion of angiotensin I to the potent vasoconstrictor angiotensin II. This not only drops the pressure by preventing vasoconstriction, but it fundamentally halts the structural smooth muscle remodeling we talked about earlier.
ARBs, angiotensin II receptor blockers, like losartan. They block the AT1 receptors directly, frequently utilized if the patient develops that maddening, dry, bradykinin-induced cough from the ACE inhibitors.
Calcium channel blockers, amlodipine, nicardipine. They bind to the L-type voltage-gated calcium channels in the vascular smooth muscle, preventing the calcium influx required for actin-myosin cross-linking. They forcefully relax the rigid pipes.
Beta blockers, metoprolol, labetalol. They antagonize the beta-1 adrenergic receptors on the myocardium, exerting negative inotropic and chronotropic effects, meaning they slow down the heart rate and reduce the raw pumping force. And diuretics, like hydrochlorothiazide, which target the distal convoluted tubule in the kidney, blocking the sodium chloride supporter to flush excess sodium and water out in the urine, directly dropping the intravascular volume.
But here's the most critical life-or-death nuance embedded in the clinical guidelines.
Oh, this is important.
In a true malignant hypertensive emergency where you have a patient with grade 4 retinopathy and raging papilledema, you absolutely cannot just rapidly drop their systemic blood pressure down to a healthy 120/80.
You cannot. Why is that contraindicated? Wouldn't the immediate reduction of hydrostatic pressure be the primary goal?
Absolutely not, because you have to remember the autoregulatory curve. Under chronic massive hypertension, the autoregulatory set point in the cerebral and optic nerve vasculature shifts severely to the right. Those incredibly stiff sclerotic narrowed vessels have biologically adapted. They now literally require a massively elevated systemic pressure just to force enough blood through their narrowed lumens to perfuse the brain tissue.
Oh, God. I see the physics of it.
If you hit them with powerful IV antihypertensives and suddenly plummet their systemic pressure to normal levels, those rigid pipes simply cannot deliver the volume. The perfusion pressure drops below the critical threshold, and you will instantly plunge the optic nerve and the cerebral cortex into massive widespread ischemia. You will actively cause a devastating ischemic stroke by lowering the pressure too rapidly.
That is the most terrifying pharmacological tightrope imaginable.
It is intensely delicate. The guidelines mandate a highly controlled, gradual reduction of mean arterial pressure, usually no more than 25% in the first hour, managed entirely in an intensive care unit with titratable intravenous agents.
Wow, okay. The systemic mechanics are terrifying. What about targeted ocular interventions for the local damage?
Typically, if you successfully lower the systemic pressure, the retinal manifestations slowly resolve. The hemorrhages are reabsorbed by macrophages, the tight junctions heal, the swelling dissipates. But if the macular edema is severe and threatening central vision, you need localized chemical intervention, namely intravitreal anti-VEGF therapy.
Bevacizumab, ranibizumab.
That was an exceptionally precise phonetic execution, especially given the sheer volume of ethanol currently saturating your cerebral cortex.
Thank you. It required an immense, almost painful concentration of my remaining frontal lobe resources.
These monoclonal antibodies are engineering marvels. They physically bind to the circulating vascular endothelial growth factor, specifically the VEGF-A isoform, neutralizing it before it can dock with the VEGFR2 receptors on the endothelial cells. This rapidly shuts down vascular permeability and stops the massive fluid leakage. And to deliver it, an ophthalmologist literally injects the antibody straight through the pars plana directly into the vitreous jelly of the eye.
Corticosteroids like triamcinolone or dexamethasone implants can also be injected to crush the local inflammatory cascade, though they carry a significant risk of inducing intraocular pressure spikes of glaucoma and accelerating cataract formation. And laser photocoagulation is kept in reserve. It uses a thermal laser to intentionally burn and destroy areas of the peripheral retina that are permanently ischemic and dead, silencing their chemical cries for oxygen so they stop releasing the VEGF that drives the leakage.
It is the ultimate form of triage damage control, burning the village to save the town.
Which logically brings us to prognosis and prevention. the clinical lifestyle modifications. Adherence to the DASH diet, aggressive sodium restriction, weight reduction, smoking cessation, consistent aerobic exercise.
Reducing the intake of high-proof alcohol.
Oops. Our adherence to the preventative guidelines today is spectacularly compromised. But here is the section of the text that genuinely, deeply devastated my emotional state.
What's happening?
The literature explicitly states that while the acute exudative signs, the hemorrhages, the fluid, may partially reverse once the pressure is controlled, the chronic arteriosclerotic changes are absolutely permanent.
Yeah, the intimal thickening. The hyaline degeneration. Once that flexible, highly adaptive living pipe is chemically remodeled into a stiff, fibrotic silver wire, it never, ever reverts back to a soft, compliant hose.
It's a permanent structural reality. The damage is permanently etched into the architecture. The youthful elasticity is extinguished. My peripheral resistance vessels, they will never possess the compliance they once had.
Hey, focus your vision on me for a second.
I am mourning the irreversible loss of my youthful vascular compliance. I'm just a walking, talking network of stiff, calcified pipes, slowly waiting for the transmural pressure to exceed the tensile strength of the wall.
Listen to my words. You are a miraculously beautiful, incredibly resilient, highly complex network of biological engineering. You're actively surviving. Your vascular network has successfully maintained adequate perfusion pressure to your vital organs for your entire life.
They're so rigid and fibrotic.
They are distinguished. They possess immense structural character. Honestly, looking directly into your orbital windows right now, despite the severe ethanol intoxication and the impending emotional breakdown, you possess the most structurally sound, aesthetically beautiful central retinal arteries I have ever had the privilege of conceptually visualizing.
Oh.
I am entirely confident that your local metabolic autoregulation is still fiercely fighting the good fight.
You genuinely mean that?
I do. You have an undeniably robust, highly attractive choroidal circulation.
You are an exceptionally supportive friend. And a wildly confusing, highly specific medical flirt. We need to finalize this protocol. Let's synthesize the data for the listener before our Broca's area completely shuts down and we lose the physical ability to formulate syntax.
Okay, the final overarching synthesis, the fundamental takeaway.
Here it is. Hypertensive retinopathy is not, and has never been, merely an isolated ocular pathology. The eye is simply the only anatomical location where the tissue is transparent enough to visibly witness the violent storm raging inside the closed system. It is a highly critical, directly visible biomarker for systemic, progressive, and potentially fatal cardiovascular and neurovascular destruction.
The exact microvascular injury you observe under the ophthalmoscope in the retina, the sustained vasospasm, the hyaline sclerosis, the plasma leakage, the localized infarctions, is the exact identical injury occurring simultaneously in real time deep within the nephrons of your kidneys and the delicate parenchyma of your brain. The eye is the brain. The body is one inescapable interconnected hemodynamic machine.
Which leaves us with a final, slightly terrifying, heavily slurred, but philosophically necessary thought. A provocative concept for you to mentally chew on while you urgently schedule an appointment to have your systemic blood pressure evaluated.
Oh, this is going to be profound. Lay it on them.
If your eyes are essentially clear, illuminated windows, offering a direct, real-time broadcast of the devastating wear and tear occurring inside your heart and your brain, what other deeply hidden, highly critical internal organs are silently screaming for oxygen right now, suffering under immense hydrostatic pressure that we simply do not possess a window to look into? What silent, catastrophic microvascular damage is quietly accumulating in the absolute dark, just waiting for the pressure to finally exceed the structural limit?
That is deeply existentially unsettling and undeniably pathophysiologically true. We are all just blindly managing the internal pressure in the dark.
Exactly. Thank you all for accompanying us on this chaotic, highly technical, emotionally volatile journey. This has been Off the Record.
Thank you for tolerating our deteriorating executive function. And Ryan Thomas, you absolute tyrannical architect of our hepatic destruction. I deeply resent the cardiovascular stress of this bourbon, but I am actively blowing a highly affectionate kiss to the control booth right now. You beautiful, sadistic, genius bastard.
Like and subscribe to Hamadugar.
We deeply appreciate your algorithms. Keep your vessels compliant and soft.
The thing is, Lisa Neeson, she really did lease an incredibly nice Nissan.
Shut up. Just finish the 130 proof.